So thank you so much for the organizer and Marie Alon for inviting me here. My colleague and friend, Dr. Victor Zapeda for pitching in my name. It's a pleasure to be on the happy side of North America. As we have spent the morning talking about TTR, I'm actually gonna bring it back to light chain amyloidosis, and I've been tasked a little bit to give an overview of how do we understand the therapies that are currently available in light chain amyloidosis from the perspective of basic science. So I just wanna give you a quick rundown. I know you had plenty of talks yesterday about light chain amyloidosis. But basically, light chain amyloidosis, we think about it as a cousin of multiple myeloma, a cancer of plasma cells. We think that both these diseases stems from the same process where you have a cells that goes bad, basically in the germinal center during an encounter with an antigen and acquire an initial mutation. And then these cells finish its development into a full-fledged plasma cells. These are the cells in your body that produce antibodies and that defend you against infection or respond to immunization. Now, these bad cells transfer to the bone marrow, and in the bone marrow accumulates a number of genomic events, so accumulates a number of DNA mutation that makes it more prone to proliferate. And when we think about plasma cell disorders, I oftentimes refer to, I don't think you can actually see the pointer, I often refer to the colon polyps. So the process is not that different. When I'm sure you're all aware of the colonoscopy screening that we undergo to detect colon cancer, that would be the equivalent of multiple myeloma. Well, we don't go and look for colon cancer. We look for a precursor of colon cancer. We look for polyps, so these small bleeps that are not quite cancer, but they have the potential to become cancer. So MGUS, or monoclonal gammopathy of undetermined significance, is the equivalent of a small polyp. It's not cancerous, but it's anomalous, and it has the potential over time to become cancer. And then through there, it grows bigger and becomes smoldering myeloma, and eventually becomes an active cancer, multiple myeloma over time. So this is the typical paradigm of evolution of plasma cell disorders from MGUS into multiple myeloma. There is a curve, though. There is a part of this pathway that doesn't quite go as designed here, which is in those patients that actually evolve into light chain amyloidosis. We don't quite know what happened at that crossroad and why a cell commit to one place versus another. We have hypotheses about it. But regardless, the main difference between light chain amyloidosis and multiple myeloma is that in light chain amyloidosis, the cells are not directly responsible for the damage. So it's actually not the expansion of the plasma cells that cause harm to the patient. It's that bad protein that these cells make, the immunoglobulin-free light chain, that is sticky, aggregates, form amyloid fibrils, and then procure organ damage to our patients through the fibrillogenesis. Now, any organ in the body can be affected by light chain amyloid deposition, we think, but there is definitely a skewing of distribution in terms of which organs are mostly affected by this disease. And the heart is really queen, right? So 75% of our patients have a certain degree of heart damage, with about 30 to 40% of patients presenting with advanced cardiac damage. And the kidney is a second close. Now, when we stage this disease and when we think about prognosis, when we meet our patients, like what lays ahead of us, the heart is really the main determinant of short-term survival for these patients. And so that's why early diagnosis is so critical to pick up these patients before the deposition of amyloid in the heart is very advanced. Now, I think this slide can start sort of addressing some of the questions that have been asked during the prior session, and so I'm glad that I followed through that one. You can tell I'm Italian by the quality of this drawing, evidently, right? So I drew this myself, so I congratulate myself every time I see this slide. So we start out with what is a femur up there, okay? That's a femur, so that's a long bone in the body. That's where hematopoiesis takes place, where blood cells are made. That's where plasma cell lives, the good one and the bad one. So if you have a patient with light chain amyloidosis, you will find the anomalous plasma cells in the bone marrow. And now these cells, as we said, they produce this unstable free light chain, and then from there they deposit in the heart. So why do we care about seeing these patients fast, early, and get them on treatment that works? This is really a disease where time is of the essence. And the reason for that is that if you diagnose a patient early and you put them on appropriate, highly effective treatment, and you reduce or basically ablate completely the production of that free light chain into the blood, then the patient has, you have maximized their chance of recovering cardiac damage. And so we know that the body is equipped with mechanisms, specifically cleanup cells that are called macrophages, that can go in any organ of the body, we think, pick up this amyloid, breaks it into pieces, and eat it and remove it. And so there is chance of organ recovery, when we diagnose a patient with any kind of amyloidosis, but in this specifically cartoon with light chain. Now, if that goal is not met, so if we're too late, the therapy is ineffective, we incompletely treat the disease, and the light chains really never normalize, then what we think happens is that there is a fibrotic reaction. So you think about fibrosis the same way you think about a scar. So there are cells in the body that are trying to contain the damage or fix in a way where the damage happened, and they do so by producing a scar tissue. Scar tissue is non-reparable. So that's a scar that is not going to go away. And these patients are going to have irreversible cardiac damage. And eventually, in the advanced patients with cardiac failure, that's the main reason that they die. So as I said, the staging system of light chain amyloidosis is different than any other staging system really in oncology. Because we really don't look at the plasma cell burden or the tumor burden per se so closely. What we look at is the effect of that on the body. And again, what we look at is the effect of the fibril deposition in the heart. So pretty much any staging system you look at to qualify how advanced the amyloidosis is, look at cardiac markers, NT-proBNP and troponin as a readout of how extensive has been the cardiac damage. In my institution and most of other institutions, we prefer to use the Mayo 2004 with European modification staging system. That's the bar at the bottom here in this histogram, because it is the staging system that can discriminate with the highest accuracy which patients are at impending risk of death, so survival less than 6 months from diagnosis. This is a critical need in amyloidosis to identify those patients early, treat them quickly with highly effective therapy, and in fact bring in more therapies that can help stabilize the heart dysfunction while we attempt to put them in a hematological remission. So this is sort of a derived version from that initial cartoon, this is a reflection of a drawing that I do by hand every time I see a new patient with amyloidosis in the office. It's a bit better than what I do by hand. But again, we're starting back from thinking about light chain amyloidosis as a disease that is born in the bone marrow. Okay, that's the initial phase where the cells live. Then there is a blood phase. That's where the free light chains that are still soluble, they're not normally shaped, but they're still distributed soluble in the blood live. And then there is a phase that is the insoluble deposition of these light chains. So once they form these aggregates that are long, they're no longer in the blood, but they're actually depositing in the heart, in the kidney, in the liver, and everywhere else they go. So I structured this meeting with my patients in a way that we understand these different phases of the disease. And I think I want to use this to also understand the different phases where we're looking to develop new therapies or where therapies are already approved. So we start off in the bone marrow. So that's the first stage of this disease. And factually, this is the stage where we have the most therapies in light chain amyloidosis, and the only stage where we have an FDA-approved therapy for this disease. So if I was to be asked what's the ideal therapy for a patient that is diagnosed with light chain amyloidosis, I will give this very clever answer. I'm sure nobody has thought about it before me, which is the one that achieved the deepest response in the shortest time at the minimum risks, right? So that would be your ideal drug, right? So how close are we to the ideal drug? We're getting closer, so it's getting warmer, okay, as compared to where we were standing before. And really, the major improvement in the approach and in the care to patients with light chain amyloidosis has been the introduction on the CD38 targeting antibody daratumumab. So this drug really completely changed the outcome of patients with light chain amyloidosis and was formally studied in a very large intercontinental phase 3 study called Andromeda that compared 4 drugs combination with daratumumab, cyclophosphamide, bortezomib, and dexamethasone versus what was considered the standard of care, but in fact was never really approved or never studied in a phase 3 study. There was only the last 3 drugs combination. This was a huge effort and a huge undertaking from the community and pharma, and the data were, spoke very clearly. So the quadruple therapy really beat the triple therapy by far in really any endpoint, primary and secondary endpoint of this trial. And particularly, you see in the upper histogram how the patients that receive 4 drugs achieve much more deeper remission and more frequently as compared to those who received 3 drugs. These remissions were about 50% complete hematological response, and most importantly, on the right, you see the purple histograms are the cardiac response and the renal response in the patients that received quadruple therapy, as compared to the orange histograms. Those are the patients who receive only 3 drugs. So you see how the patients achieve doubling of the response at the level of the heart and the kidney if they receive daratumumab in combination with CyBorD. Now, obviously, there is no perfection, right, in human life in general, but so the same in medicine. About 20% of the patients that were enrolled in this large study either did not achieve a response at all, so they progressed, or they had stable disease on the quadruple arm, what we call primary refractory disease, or they achieve a response that we do not consider conducive to an organ response. So it was not good enough to guarantee or maximize the chance of organ recovery. So still some issue out there. Regardless, the quadruple combination resulted in prolongation of this then new primary endpoint that was introduced, which is a combination of the typical endpoint in hematology oncology, which is the progression-free survival, or PFS. That's you live without your hematological disease, so you live free from disease. So combine that endpoint that looks really only purely at the hematology side of the things with these major organ dysfunction or major organ deterioration endpoints that looks at death, it looks at cardiac transplant, it looks at renal transplant. So now you have a combination that is very specific for light chain amyloidosis patients, where we're not just looking at how good are we in putting them into a hematological remission, but how good is it from the standpoint of the organ perspective? So no need for a cardiac transplant, no need for a heart transplant, and patient leave. So as you see, these curves look good from one point on. So there is clearly the upper curve, the DARA CyBorD does better as compared to the CyBorD, but this does not happen up until 7 to 9 months from randomization. So that means that we're losing really the main amount of patients, whether we give them DARA CyBorD or CyBorD in that very early interval time. So if we think about, these days, how we would approach a patient with newly diagnosed amyloidosis, light chain amyloidosis, I think the first red square there, red rectangle there, outline the importance of considering offering to your patients clinical trials. This is a disease where we only have one FDA-approved therapy. We can do a lot by offering clinical trials to patients, allowing them to get access to medication that they would otherwise not have access to. That's a first point. But then in general, what we would do in our own center would be to offer to everybody DARA CyBorD based on the result of the Andromeda study. And then have a second crossroad, which is whether or not your patient is eligible for an auto stem cell transplant. So can we sort of consolidate or deepen that response elicited by DARA CyBorD with an auto stem cell transplant? If your patient is eligible and the response that they have derived from the chemotherapy is not great, then we would offer an auto stem cell transplant. If they're not eligible, or if they're eligible and they're already in a deep response, then there is no strong indication that a transplant should be pursued. The question of auto stem cell transplant in light chain amyloidosis remains open, though. We don't know in the era of very highly active therapy what we should do with transplant. 20 years ago, it was everything really we could offer a patient was an auto stem cell transplant. these days we have a wealth of options that are highly effective, and so where the transplant fits into this option is unclear. It's also, we know, to hold true the fact that only about 20% of patients with light chain amyloidosis would be fit enough, well enough, and have social, financial consideration taken care of to make them eligible for an auto stem cell transplant. So this is a vast minority of patients that will ever be eligible to receive this therapy in their lifetime. So the DARA-CyBorD based on the Andromeda study was approved for patients who have what we call stage 1 to 3A light chain amyloidosis. It did not include patients with 3B disease. These are the patients that have the most advanced cardiac amyloidosis and those that are at the highest risk of mortality within those 6 to 12 months. So what are we doing for these patients? That's a bit variable and depends on center by center. In our own center, we offer all non-frail patients DARA-CyBorD, and so we would treat them the same way we would treat any other patients with light chain amyloidosis, and there are data emerging that this appears to be a highly effective strategy and not more risky overall than the triple combination only. And we know already that part of the reason why this quadruple combination works so well is because DARA gives an extra kick in terms of putting patients into a hematological remission very fast. So you can see here in the waterfall plot how fast the light chain decline after one single dose. So this is not a cycle, this is not a year, this is one single dose of medicine. So it is exceedingly active in normalizing or near normalizing the light chain in the vast majority of patients. And this is really critical, as we said, to avoid that fibrotic process and irreversible cardiac damage. So what is the DARA-CyBorD did not do? So I showed you already the MOD PFS curves. That is a compound endpoint. It's hematological remission and organ dysfunction or major organ deterioration. So it turns out that most of those patients that decline, that we lost in those curves, we actually lost because of cardiac death. So the issue in this trial was the early overall survival. And as you see, these are the overall survival curves. They're basically exactly overlapping within the first 1 year. So what DARA-CyBorD did not impact is the early mortality. And again, this trial did not include the sickest patients, and so presumably those patients, even with DARA-CyBorD, will probably not be rescued from the early signal of death that we see in advanced stage cardiac amyloidosis. So what is beyond DARA-CyBorD? So beyond DARA-CyBorD, there is a lot of excitement, there is a lot that is happening. This is a cartoon that I put together a few years ago. And honestly, most of the drugs or the targets that you see in these cartoons are borrowed from multiple myeloma. So typically what works in multiple myeloma will work in light chain amyloidosis. The cells looks honestly quite the same. They may not have the same safety profile, but technically they are expected to have some degree of efficacy similar in myeloma. The only difference really from myeloma is in the upper left corner. So you have heard about depleters in TTR. I heard question about do these depleters work in light chain amyloidosis, so we're going to discuss a little bit about that in a second. But we now have drugs in clinical development who serves the purpose of recruiting those macrophages to the amyloid in situ, so in whichever organ is involved by the amyloid, and elicit the accrual and pickup of the amyloid. I just want to focus on a few targets that are in development, which I think are the most exciting, the most promising. One is venetoclax. This is a small molecule drug, is FDA approved for treatment of certain hematological malignancies, some form of lymphoma, and acute myelogenous leukemia, and it targets this organelle, the purple organelle at the bottom, the mitochondria. And what it does, it binds to a protein that sits in the mitochondria and tells the cell to die. So it's a suicide inducer drug. And it works exceedingly well in patients with light chain amyloidosis who harbor this translocation that is called 1114, which result in overabundant dependency of those amyloid cells on the BCL2 protein, which is the target again of venetoclax. So if you look here, these are histograms related to multi-center retrospective data. looking at all patients that receive venetoclax in certain combination or as a single agent, divided in translocation 1114 versus not. So the second histogram is the the non-translocation 1114, and the last histogram is the translocation 1114, where you see that really most of the effect of these drugs is in the patients that harbor a translocation 1114. At the bottom, you see PFS curves and overall survival curves, where in red you have 1114 patients versus not. And you see how these patients do much better from the standpoints of holding on to a hematological remission with a signal for positive impact on survival. Now, this was a case report that showed what happened to the free light chain concentration in a patient that had multiple relapse refractory light chain amyloid, having gone through Cyborg-D, melphalan dexamethasone, lenalidomide dexamethasone, DARA single agent, and really the red curve didn't really budge much up until this patient got put on venetoclax, where you have like this rapid plummeting, and patients who are treated with this really do this quite often, where the free light chain basically normalized within a cycle. And this particular patient subsequently experienced remission of dysfunction at the level of the heart and the kidney, and a very deep hematological remission. So these drugs really looks great. It's used off-label, so there is no label approval for AL amyloidosis, and unfortunately, there is not a label approval in myeloma either, but it's a great resource if it can be secure for patients with 1114. And the second target that I want to talk about is BCMA, B-cell maturation antigen. This has been the major breakthrough, I want to say, in the past 5 to 10 years in plasma cell disorder. It's a surface protein, is a receptor for certain cytokines that are in the bone marrow microenvironments, and it is highly and very specifically expressed by plasma cells, kind of all kind of plasma cells, normal plasma cells, myeloma plasma cells, light chain amyloidosis plasma cells. Now, BCMA has been the interest of major development in immunotherapy and cellular therapy in recent years. So the first drug that we're going to discuss about is called belantamab mafodotin. This was the first in its kind antibody drug conjugate that hit the market in multiple myeloma. What an antibody drug conjugate is the association between an antibody that works as a carrier, so in this case is a BCMA antibody, so an antibody molecule that recognizes the BCMA protein, and what this molecule does once it binds to that BCMA protein is that it carries inside the target cells a toxin. In this case, this is a microtubule stabilizing toxin that then kills very specifically only that one cell that has been engaged by the antibody, and therefore avoids generalized toxicity related to the systemic administration of the toxin. So it works into multiple ways. It blocks the receptor, so the BCMA, from transmitting pro-survival signal in amyloid. It releases the toxin inside, and also upon engaging of the receptor, causing the immune system to kill myeloma cells or other kind of plasma cells. So belantamab has been used off-label in light chain amyloidosis, again, with really quite staggering success and very specific remission of disease in patients with highly relapsed refractory light chain amyloidosis. Unfortunately, clinical trials were halted in light chain amyloid as this drug was withdrawn from the US market after approval in myeloma as a consequence of a trial that did not meet a primary endpoint. This decision may potentially be reversed in light of more recent trials that appear promising, and we have been able to secure these for patients with myeloma and light chain amyloidosis through an extended use program. What else is being developed? So BCMA has been leveraged to develop immunotherapy and cellular therapy, and there are quite smart strategies really to leverage and steer the immune system into hunting down light chain amyloidosis on multiple myeloma. These bispecific T-cell engagers are molecules that have two arms. On one arm, they bind a specific antigen, in this case BCMA, and therefore they grab the plasma cells. With the other arm, they bind CD3, which is a universal marker for T cells. So they grab a T cell, they grab a myeloma cells or light chain cells, and they bring them together. And then the T cell does what its job is, which is to kill the other cell on the other side. So this has been proven like extremely effective treatment in a variety of hematological malignancy, and we finally have approvals also in multiple myeloma. Some of these drugs have been looked at retrospectively in patients with light chain amyloidosis. These are data on teclistamab, which is one of these BCMA targeting BiTEs. We have our own paper submitted looking at elranatamab, that's a Pfizer compound. They all look really good. Responses are quick and very deep. And clinical trials are happening right now as we speak with a number of these compounds in light chain amyloidosis patients. And then CAR T, you cannot be an oncologist, hematologist without talking about CAR T. So these are engineered cells derived from the patients. They get modified by expressing a particular T cell receptor that would engage one particular molecule, or in some cases more than one, on a target cell. So there have been major breakthrough in medicine. They have had curative intent in BALL, so B lymphocytic leukemia, certain kind of lymphoma. And then now we have 2 products that are approved in myeloma, again targeting these BCMA proteins. There has been one trial reported actually of the use of BCMA targeting CAR T cells in light chain amyloidosis. This was a compound developed in Israel through an academic effort. The data looked encouraging. It's a bit early. Not many patients were treated at the time, but a larger phase 2 study is actually taking place right now in the United States with these actual compounds specifically in relapsed refractory AL amyloidosis, so we will surely know more in the upcoming days. So that concludes the femoral phase, the bone marrow phase of what drugs we have out there that work in this disease, and we move on to the next phase, which is the blood. So when I was putting together this talk, I actually had the not so, I don't know, politically correct idea to put out there the image of the nothing. I don't know if you guys were fond of the Never-Ending Story as much as I was, but the nothing is what chews up Fantasia, okay? So it's like there is nothing out there, there is no inspiration, we're lost. And then, you know, we're not quite lost, and so I peeled that back. So what are we thinking here, right? So I think we discussed about the importance of understanding basic science to design drugs. The thinking here is that there is something special about the free light chain that makes amyloid, which is evidently different than the free light chain in multiple myeloma that doesn't make amyloid. We don't quite understand this process in greater details, and it's a very complex process, we think. But if you are very simplistic and you look at this in very simplistic terms, we have all had the experience as physicians of treating patients that were diagnosed with light chain amyloidosis in the presence of a different burden of disease in the bone marrow or a different burden of circulating light chain. So there is something specifically about the sequence of the immunoglobulins light chain that makes it more prone to aggregate as compared to others. And so you can develop symptoms of this disease early on in the course of that plasma cell disorder timeline that we discussed about, if the protein is very sticky and the aggregation happens very quickly, as compared to a less sticky protein where the aggregation happens much later. This is also a phenomenon that is very well understood by physicians who treat light chain amyloidosis, is that patients with this disease, at one point they become symptomatic, and when they become symptomatic very fast. And the evolution of symptoms is really at an exponential speed. And we think this is a reflection of really the physical property of the aggregation of the amyloid, where you have this long lag phase where you're forming like just small aggregates of the amyloid, like little oligomers, but they're not quite insoluble yet. At one point, these oligomers becomes larger, they form protofibrils, and then eventually you get what we call a seed, so that there is initial deposition of a decent amount of amyloid fibrils in an organ. And once that occurs, then it catalyzes very rapidly the aggregation of more and more fibrils in a very short period of time. So that's in reference to the pancakes, that we were discussing before. So these pancakes start to stack very fast. And that's the exponential phase of elongation, and that's where people get exceedingly sick, exceedingly fast, and that's why we want to stop this process very rapidly from occurring by normalizing the light chain. Now, the efforts have been much towards the development, basically, of etafamidis for light chain amyloidosis. And I'm not going to go into the details of these because it's very tricky and very elegant chemistry, actually run by the lab of Jeff Kelly, who also developed tafamidis in the first place. What suffice to say is that this is a very different problem than the tetramer of TTR. You're talking about binding to light chains that are different in each patient, right? So there is a huge biological variability. There is a huge difference in terms of the stability and the kinetics of the dimer-dimer association. And so this problem has proven to be a bit more tricky than a tetrameric structure that is always consistent and always the same. But this work is happening. It's exciting work, and it obviously will work as a buffering tool to avoid further light chain deposition as we're treating amyloidosis and killing the cells in the bone marrow. And finally, I'm going to focus a little bit with the targeting of the fibrils in the organ. I understand I'm between you and the lunch. That's never a good place to be. So I'm just going to go through these relatively quickly, and I'm happy to take questions later on and lunch break and so on and so forth. So antifibrillary antibodies are here, right? So similarly to what you heard about TTR, we have antibodies that were specifically or serendipitously designed and derived and then eventually worked through the kinks of clinical development for light chain amyloidosis. So going back to that question that was asked, are these stabilizer, do they work in all diseases? No, they don't. It depends really what antigen they're built against. So the one that you heard of that specifically recognized the TTR epitopes would only work in TTR. We have now antifibrillary antibodies that are designed against epitopes that come from the stretch or dearranged light chain. Again, those will only work for light chain amyloidosis. But, there is always a but, there is something else also happening. So there is some effort in developing pan-amyloid antifibrillary antibodies. For instance, these AT02 molecules bottom down there, it has been developed in a different way than the other two molecules that you read here. In a sense that this is an antibody that carries this small peptide, this P5 peptide, which then binds to a common protein that is present in all kinds of amyloid. And so it binds to these glycosaminoglycans, which are part of the extracellular matrix, and they get intercalated with any kind of amyloid. So we think of these particular antibodies as an antibody that will, flag and tag any kind of amyloidosis just based on their chemical structure, regardless of what is the protein precursor protein. This is very early. They're in early phase 1 to 2 clinical development, but they're very promising agents. The agents that we have in most advanced clinical development, you see listed here, birtamimab, what was previously referred as the NEOD-001, and anselimimab, previously referred to as KALM-101. These antibodies are slightly different in terms of what epitopes, so what stretch of proteins in the free light chain they recognize. So you see birtamimab recognize an epitope at the C-terminus, at the end of the kappa and lambda free light chain, while anselimimab recognize an epitope at the beginning of the protein. I think what I outline here is data that are preclinical data that I think are relevant, which is what do these antibodies exactly do? So we have no data of anselimimab actually binding protofibrils, so those small stretches of oligomers that are still in circulation. However, there is preclinical data that birtamimab can do that. And so the idea here is that you can bind the fibrils that is in the heart, in the kidney, and so on and so forth, and reabsorb that, while at the same time buffering and sort of taking away these small oligomers there are the building blocks of then the longer fibrils. Both these products are in phase 3 clinical development, with the anselimimab products having completed accrual and the birtamimab products being currently accruing. What is the rationale to use this drug, and how have we thought about using this drug? So if you think about it, what problem these drugs are addressing is the early mortality, right? So the signal that we saw in patients dying from irreversible cardiac damage as we were treating them, or as we were starting to treat them, or even when they were in a great hematological remission, yet the heart damage was just too profound. So on top you have your chemotherapy, your chemoimmunotherapy. What that does, it kills the cells in the bone marrow, basically shutting down the whole process, right? Abating the light chain release and impeding any further amyloid deposition. What the drugs don't do is to remove the amyloid that is already present in the organ, and that's where we hope, that the antifibrillary antibody are going to do the job. So if you combine them together, the hope is that you can guarantee the maximum overall survival in the long term, as well as abating that signal of early mortality. So this is really mostly what these clinical trials are looking to prove. Preclinical data were really strong for this molecule, and the early phase clinical data were really excellent. So you see on the left, this is anselimimab, the Kelun product, or the AstraZeneca product now. So these were measures of how well do they work based on the decrease in NT-proBNP, a measure of the stretching of the heart, as well as an improvement in the global longitudinal straining, so how well the heart relaxes. So in early phase clinical trial, anselimimab showed that there is promise that the heart can remodel, and that this product should move ahead in further phase of development. On the right, you actually see overall survival curves. So this is a quite impressive endpoint derived from a previous phase 3 study of the birtamimab molecule across all stages of light chain amyloidosis. Now, if you zoom in the most advanced stage that was used for this one particular protocol, the stage 4 disease, you see how patients that received the drug in blue had a much better overall survival as compared to patients who received placebo. And so these data, that was a post-hoc analysis of this larger trial, informed the design of the current birtamimab study that is exclusively looking at this patient with stage 4 cardiac amyloidosis. So what we are trying and hope to do here is that this medication may offset the need to refer patients for cardiac transplantation. So this is a huge unmet need in light chain amyloidosis. We have extremely sick patients. There has been no consistency or no agreement really in which patient should be offered an organ, when faced with a diagnosis of light chain amyloidosis. What we know, though, is that we're doing much better from a hem-onc perspective. We have better therapies, patients can live longer, and if you look at the bottom line there that I outlined, these are data coming from Germany, the University of Heidelberg Transplant Center. They had 16 patients transplanted who received a cardiac transplant with a diagnosis of light chain amyloidosis between 2002 and 2007, and 16 will receive a heart between 2008 and 2017. And if you look at the last column, that's the overall survival at 5 years post-transplant, post-cardiac transplant. The survival has more than doubled. So it was 31% in the first cohort of patients, and in the most recent cohort of patients is 77%. So that reflects the fact that we can salvage relapse of light chain amyloid after a cardiac transplant with new therapies, more effective therapies, which is something that we couldn't do 10 years ago. So I just want to leave you with actually work from my own lab. As you hear, I'm a clinician. I take care of patients with light chain amyloidosis. I also run a basic translational science lab in plasma cell biology. And I specifically work on light chain amyloidosis as the center of our interest. So, and as you heard, in the talk just prior to me, I'm also a deep believer that the fundamental improvement in the way we develop drug only comes if we have an understanding of how the target of the disease work, right? And so it was sort of surprising to me when I opened my lab not too long ago that we actually don't know how free light chain makes it out of plasma cells. So you would think, this is a rather important process, immunoglobulin release, light chain release, but actually all the work about secretion of protein was really done in the early days at the level of the central nervous system, right, looking at neurotransmitter disease, and the pancreas, right? Insulin is good, is important, yeah? So, but there was nothing about plasma cells at the time that we started working on this. So we put out a very simple hypothesis. So we hypothesized that light chain get out of plasma cells the same way that insulin get out of the pancreas, or the same way that acetylcholine comes out of axons. And this was a testable hypothesis, and so we went for it. So how do these proteins mix it out of these cells is through a network of proteins that are called Snare's protein. Snare's protein are infamously known because they are the targets of botulinum neurotoxin, or Botox. So you all know Botox, right? That's the reason you don't give honey to your infant children, right? So it's the most potent toxin at this point that we knew of. And it works by basically binding to this Snare's protein that sits on secretory vesicles, on these little loops inside the cells that bring proteins outside. And once it binds to them, it cleaves this protein and impedes this release of whatever protein is the cargo inside those vesicles. It is a rather elegant chemistry with the way that the vesicle and the membrane interacts, and it's a complex of 3 different proteins, 3 different snares that participate in this. So we basically hypothesized that the same mechanism is true for free light chain secretion, and that we could identify exactly this complex in plasma cells. So the hypothesis of all this work was very simple, actually, at the beginning. So if you think about the natural history of light chain amyloidosis, you have a plasma cell. We hypothesized that these plasma cells pack the free light chain in this Snare's-coated vesicle, and then through that mechanism, they make it outside the cells into the blood, and then from the blood into the heart or anywhere else. So if we were true about our hypothesis that this is the mechanism that brings light chain outside, at 1.5 years, I have a patient, I have so many that are like NIA class 1. One went to run back half marathons, after finishing treatment. And she's doing fantastic. The NT-proBNP is almost normal, it's great. And the MRI is 0 change, like nothing at all. So there are things we don't understand, what happened in the extracellular volume. Maybe the fibrils are still there, but they're broken down, they're very tiny. So the extracellular volume has not shrunk. And yet the patient, can have better diastolic function, can evidently do much more. So I think the role of imaging in this arena is somewhat up in the air. I have a lot of hopes and a lot of feelings about molecular diagnostic and molecular imaging, so dyes that bind to the amyloid, right, and then can map the amyloid in the heart. As those dye appears to be more sensitive, so we see disappearance of florbetapir, for instance, like at the 6 months, 1 year mark in patients in a hematological remission. So I think the molecular diagnostic, as it becomes hopefully approved and supported as a diagnostic and a monitoring technique, will give us better idea of what's really happening in the heart in patients that respond versus not.
Any other questions?
And Marie doesn't want to eat. Thank you.
Oh, thanks, Helen. Just a question. I'm not sure if we have any. Data on it. What's the percentage of people that would have myeloma as well as AL? And do we have any idea why some people get both? Is there a particular reason why both can occur? And what would be the first to occur?
You shoot close to my heart. So we're looking at these in the laboratories right now. So the percentage of people that will have clinical diagnostic criteria for myeloma and amyloid is about 10 to 15% of patients. Or this is what has been written in the books and what we know historically. So I think that number it's going to change because the way that myeloma has been approached is different, and there is a large push at this point to treat many patients with MGUS and smoldering right before they develop multiple myeloma. And in doing so, you're going to eliminate or largely reduce the free light chain burden in patients that have precursor diseases. And so inevitably, you're going to affect the quantity and time that free light chains have been around in patients, which is a necessary component to the amyloid deposition. So I think this will somehow reflect the changes in approaches. What makes people that have myeloma also have light chain? This is a genetically determined event. So when you are in that germinal center as a B cell and you encounter an antigen, and then you do your job, you cut the DNA, make an immunoglobulin. At this point, a rearrangement happens during this maturation process that leads to a formation of a certain amino acid sequence for the variable region of the immunoglobulin free light chain. That's genetically determined. After that, there is a process that is called somatic hypermutation, where some of those amino acids get swapped, just like change, randomly again. So we think that really an amyloidogenic sequence is determined at that time. Then we don't know how many of those people that have an amyloidogenic sequence actually will go ahead to develop the disease, because there are going to be inevitably factors outside of the protein. Namely, in our body, we have proteins in the blood that buffer bad proteins. So they grab them, they take them away. They're not safe, they don't have a normal configuration. So we have buffering capacity in the blood. That's called the proteostasis network. So we think that people have better proteostasis network, and there are people that have worse proteostasis network. And so in the face of exactly the same sequence, those people that have more buffering capacity will not go ahead to develop the disease, or may develop the disease very late. That's why maybe in the context of myeloma rather than MGUS, looping back to the stickiness point. And this is not by chance that these are also diseases of aging, right? The proteostasis network decline as we get older. And so the buffering capacity will get less and less over time, and the propensity to aggregate will get higher and higher over time. But this is a huge fundamental biological question that requires really the expertise of chemists, physicists, biologists, and so I think it's one of the hot topics that we'll tackle. It'll just take time.